But the disconnect between that and the NHS, between that and the national public health system that was, and now we've got even a more specialised agency, this worries me a lot. And I don't think it's the best for workforce development either. No wonder people are having problems explaining what public health is. And then we have the department, in there, so people getting more and more sucked into central government. But who speaks? Where is the voice now? And you'd have to think carefully about who can say what in this situation and who knows enough about the comprehensive picture of public health to say what.
Welcome to a special new series of episodes that we've launched in partnership with the Faculty of Public Health. In this series, we aim to explore one key question: what is public health? Now, it may seem like a simple question, but public health is no single thing. This series aims to shine a light on the huge range of work delivered by the diverse public health workforce as we talk to key figures in public health from across the UK to explore this question, as well as what inspired them to go into public health and what they think are the key challenges lying ahead. So today it's my absolute pleasure to welcome Professor Yvonne Doyle to the podcast. Yvonne is very well known across public health, but to give a sort of quick background, Yvonne is a medical doctor by background with over 20 years experience in public health and has worked across a range of senior leadership roles across the NHS, Department of Health, UKHSA and academia and more. Between 2013 and 2019, she was appointed the Director of Public Health for London and was the Statutory Health Advisor to 2 London mayors. And in 2016, she was awarded a CB for her contributions to improving public health. In 2019, she was appointed as the Medical Director and Director of Health Protection for Public Health England and played a pivotal role in the response to the COVID-19 pandemic. In 2022, she was appointed as the first NHS Medical Director for Public Health. And in April last year, she semi-retired and has maintained a very active role in public health across the system. Yvonne, thank you so much for joining us. It's an absolute pleasure to host you.
Thank you very much, Kazim. It's great to be here.
So actually, my first question is, how are you enjoying your semi-retirement?
Well, I'm a non-exec on a couple of hospital trusts and I'm a trustee of a charity for homeless people. I keep engaged and do occasional work for WHO. And I am a fellow of the Academy of Medical Sciences, so I do assessments for them. And actually I was there last night looking at the up-and-coming researchers, some of whom were describing core public health challenges around children.
Yeah, so still very, very active in your semi-retirement. Have you had some time to kind of relax and enjoy travelling or anything like that?
Well, everybody says they travel when you retire, and I did go to the Arctic a couple of weeks after I retired last April. But I'm not so keen on just bonding around the world. I actually really enjoy being semi-retired, doing a bit of work, a lot of it which is pro bono. The hospital and the healthcare system is very demanding, so I give quite a lot of time to that. Yeah. But I also believe you should learn new things, and I've bought a harp. I had one made for me in Ireland, and I'm learning the harp from a Belgian lady who's based in Killarney when I'm over there. So I take lessons. But being a pianist, it's actually quite a joy to learn another instrument.
Amazing. That's a very unique skill for a public health person. But, so perhaps let's start with a little bit about you. You've got a fascinating background. So in a previous interview, you gave a really good description of how you kind of discovered public health. And you kind of described public health as a fine wine. And your appreciation for it kind of came with maturity. And I really loved that sort of description. What was it that attracted you to a career in public health?
Well, actually, I'm interested you've got all this stuff. Obviously, I'm slightly terrified that people remember these things. I'm thinking, did I really say that? That's a good analogy. But I was a clinical epidemiologist. I went through my clinical training, and then I ended up in cardiology with clinical epidemiologists. And we were always asking the why question. Why are we seeing these presentations and what's going on out there? And I hear that an awful lot from a lot of disciplines really who come towards public health, is they want to know about the bigger reasons behind what they're seeing as kind of distress really. So I kept trying to do research. When I was an intern, I started going around various hospitals in the Irish Midlands on my days off from surgery. And the why was, why are we seeing so many accidents coming into A&E that initiate on farms? What is going on farms? And that led to a really great piece of work, which eventually got into the Irish Parliament as part of their legislation on safety. But it was terrific fun, but you wanted to know. And then somebody said one day, you should apply to become a public health registrar. They do this all the time and they're paid for it. So that's how I kind of started, and it led on from there. But, having started wanting to be a researcher, and I've always kept an interest in research, actually the joy of public health is really in practice.
Yeah, amazing start. Very unique with the farm accidents. And also, I mentioned the interview again, but that was also where you met your partner as well, which is kind of a fascinating story.
Still my husband, for nearly 40 years later. We used to go around together in a very battered out old Mini, taking pictures on the roads of really dangerous situations on farms. Yeah. And got the farmers involved in this. So they actually funded some of the research eventually because they got worried. And, it was a great partnership really at the time. And it taught me a lot about engaging people who know the business or know the world, and you bring your skills to the table.
Yeah, fascinating way that you kind of entered public health. So I guess to the main question of the episode that we partnered with the faculty on, obviously, as we said at the intro, public health is quite a broad discipline and isn't necessarily a single thing. I guess in your sort of own experience, in your own words, how would you kind of describe what public health is?
So public health is population focused. That is the big distinguishing factor from other disciplines which look at individuals and not just clinical. And it's I think it's very place-based. I've come to really respect the importance of understanding the place that the population or the group live in, and understanding your place as well. You need to have a respect for the environment and for what place brings to population health. But basically what drives me and what drove me in public health is the opportunity to enable people to experience the joy of health, and that experience was fairly distributed in the population. And the health is such an asset, Kazim, that people they keep saying, I never realised it until it was gone. Well, if we could get populations and people, individuals, right down to individuals, to think, this is my biggest asset. If we could get governments to think health is our biggest asset, right down from government through partnerships, through organisations, right out to individuals. Because basically it's what makes the world go round.
Yeah, I completely agree. So really kind of grassroots, local, place-based public health is the kind of focus around that. I guess in your sort of previous roles, local, I think you started off as a director of public health in one of your roles, and then had national and regional roles. What are the sort of things that you've reflected on about how to link local to regional to national? Because obviously they have very different approaches, but what are your sort of reflections on those kind of linkages of how to make that solidified at that?
I think it's very difficult. That's the first thing I would say. And my biggest respect is for local. It always was. And I was described at early days as a grassroots. So you might say, well, why didn't you stay there? Because I think, you get opportunities for leadership and you move on. And unfortunately, some of those opportunities, not all, are at a national and regional level. I think probably the best job I ever had was as a Director of Public Health in Southwest London. That was where I was a DPH for 3 boroughs and the NHS at the time. And it was just a brilliant job. And then moved on to become various regional directors, but the best regional director was for London. Because again, there was a serious sense of place there. You knew what London was. You had the great privilege of getting to know every borough in London, and that's what I loved. And then you could begin to understand the partnerships in the various opportunities in London that you could enable to get cracking for health, really. So that was good. Nationally, it was very interesting. I was a late national director, really. I was appointed to Public Health England in 2019, well, in the middle of it, just before the pandemic, and it wasn't a normal national role. and then the NHS role. I would say that both of those were quite isolating. They were terrific. You met the most brilliant people and you got noticed a lot. And of course that led me to do the platforms on Downing Street and so on. But it's exciting, but actually it's not really where health happens.
Yeah.
Health happens at the local level, in place, in groups, in families. And that's where you've got to keep your focus at national. And a lot of people lose that connection and then the system flies apart.
So so you said that was your favourite job as a director of public health. What was it about that role? I mean, was it simply because it was place-based, or was it the team or anything like that? What was it about? Because you've had such amazing roles. To take it back to your kind of one of your first roles as DPH, what was it about that DPH role that really, you reflect back as that was one of your favourites?
Because that was the first time I actually, and it's the reason I took the job, I realised that this was a leadership job. That I had actually, in my purview, my place was Merton, Sutton and Wandsworth, or places really. And I was in charge of trying to get the best out of those places for the people of those boroughs. And coming back to the sort of joy of health, why health? Why is health an asset? Because it helps people to be the best they can be. That isn't to mean that everybody has to be the same or be brilliant or go to, this university or that. It means that whatever is in their potential, they can realise because they have the joy and the enabling of good health. Now, a director of public health has to work out what is it in their place that brings the best out for the most for that, and to ensure that it's fair, that the people who really have that potential, to be what they can be, and that's everybody, but some people have more potential than others to be wonderful. Are they getting the chance to do that?
Yeah. You mentioned there about sort of leadership. So would you say that DPH role was one of the first where you were able to kind of develop your leadership style?
Very much so. And you have to know what your values are. I mean, it was one of the questions that was asked to me. I worked for a couple of years in the private sector because it was an opportunity. I had been an academic and I thought, this is good. And it was well paid. And I learned a huge amount, by the way. But, when I came back to the NHS at the time, one of the questions at the interview, which was probably illegal, was, well, what are your values? Why are you coming back here? You're taking a drop in salary, which I really did. Why are you doing that? Why would anybody do that? And I went back to the guy who was interviewing me the next day and I said, look, do you really want me as a consultant or not? Because I'm not sure that question was quite right. And, the reason you come back and do things for the purpose of the role is that your values tell you this is a good thing to do. It's a good job. It'll be fun, but it'll also be very valuable. It's worth doing.
I mean, sort of linked on that about leadership. Obviously, that's a really key area for us as registrars to develop that as you go through training, and then hopefully eventually go into a consultant position where you are leading in that sort of capacity. And obviously you've had some of the most senior leadership positions that exist in public health. How would you describe your approach to developing your leadership skills and approach? Has it as a sort of outsider, it seems like it comes quite naturally to you, but how would you kind of describe how the sort of behind the scenes of how you developed such a strong leadership style?
Well, the first thing is you have to want to lead, but how you do that is quite an individual thing. And for all the MBAs and management schools that tell you all the kind of types of leadership, actually it becomes very personal. And you will know you're a good leader for two reasons. First, if you can deliver things and you can get things done. And how do you do that? You get that done through people. I mean, your intellect, obviously, and your training and all that play in, and you can be very entrepreneurial and spot things. And that's fantastic if you're doing it for health. But how it actually happens, the execution of that isn't about brilliant ideas, it's about delivery. So good leadership makes an impact because others notice that change for the better has happened. And if you can attribute some of that to yourself and your teams and your colleagues, you're a good leader.
In another sort of interview where you kind of reflected on public health values, and it came across really strongly that it was almost as if you're kind of your North Star of whatever position or chaotic environment or situation, that your focus always seemed to be on what was the value to public health to those populations as you spoke to. Would you sort of agree with that sort of characterization of sort of how your values influence your leadership style?
So the core value for me, actually, Kazim, is integrity. And I say that because I've seen it every which way, and the more senior you get and the more noticed you get and the more into the hot zone you get, you begin to see all sorts of behaviours. And if you can come through these roles with your integrity intact, in other words, you've been, first of all, a decent, I'm not saying I'm an angel, but you need to know yourself, and your conscience will tell you, have you done the decent thing? Are you a decent person? Have you stood firm when you've stood for things that you believe are right, even if it actually damages you? And this is where a lot of people kind of go astray, because they make choices because they know this could be bad for my career, or this could be, but if you have your integrity intact, I think your reputation is quite important as well. But that follows because others are watching you all the time, and they'll know what they're looking at. And sometimes they don't like what they're looking at, but the fact is you are being observed. Always remember that. So your behaviour is important as well. So being decent to your colleagues is very, very important. You have to take tough decisions. You must be ready to do that. And being in public health, it is a privilege. We are quite well looked after, even although it's quite difficult at times to get jobs. I understand all that. But nevertheless, people are keen that we're in the system. And for those privileges, there are consequences. So, we have to make sure that we are actually, using our privileges wisely for the benefit of our teams, our workforce, but also of our population that we serve.
It's really fascinating. So really, understanding the self almost seems like as one of the values of maintaining, as you said, how people perceive you in a way. I guess my question is, how do you sort of maintain that sort of integrity over a long period of time? Because public health is, I guess, a relatively small world and small sort of family of people. You come across the same people quite a few times, but how do you sort of maintain integrity? Is it sort of do you have a sort of network of sort of mentors that kind of advise you of the sort of right approach to certain situations or career moves and that kind of?
Well, I think it's very wise to have mentors at certain times. And I've obviously quite late. I mean, when I was regional director is the first time I really experienced coaching, serious coaching. But I didn't want to become dependent on that. I think the first place you have to start is with yourself. You need to know yourself. Now, these enablers, your mentors are great. Your coaches will try and get you to reflect and know yourself, as you say. But ultimately, this isn't something that kind of withers, integrity. It was there when I was 20 and it's not there when I'm 40 or 60. You're being challenged practically every week for your integrity if you're a leader. There are decisions and there are circumstances and behaviours every day that you have to demonstrate, which hones your integrity. It's all connected, this stuff. And you don't wake up every morning and think, do I have integrity? You just get on with your job because you love it. But there are decision points and there are episodes in your week or your month where that this is actually quite a key thing. So think wisely here. Be careful. Don't do things that you will regret and that you'll certainly regret if others are involved in it. And you knew you shouldn't have taken that decision.
So from a personal perspective, there's a group of registrars. We've been doing a lot of sort of leadership training, and we've been on a course for the last, I think, three to 4 weeks. And one of the things that we've been looking at is how to deal with chaotic situations as leaders. So by that I sort of mean situations where there's a lot of uncertainty about what the impact of certain decisions, a lot of uncertainty, when it comes to the functioning towards a certain public health goal. And obviously you've had, more than fair share of experiences with sort of chaotic and challenging environments. I guess my question is, what sort of tips would you give to registrars about how to deal with, chaotic environments or sort of complicated situations that lack certainty?
Well, that's what health is about. I mean, as you know, and clinicians certainly know, you're dealing with uncertainty all the time. That's why in infectious diseases, in health protection, you do dynamic risk assessments, because all the time you're dealing with uncertainty and situations that are fluid and change. So, that is the case at every point of your career. You're not going to be asked as a registrar to make decisions that politicians will perhaps notice, or that, upend the whole of public health. It won't be like that. It will be graded. And as you decide and as people encourage you to go forward, you'll be into positions of more leadership. The most, I think, fundamental of which is Director of Public Health, which is a terrific job. And it's very different to being a consultant. But beyond that, you can take other choices. You can go into other parts of the world, the system, and take leadership roles. Now, the sort of, how do you kind of know what you will be asked, chaotic situations? Yeah. You will recognise them, that's the first thing. They'll become more chaotic as you become more senior, actually. Chaos abounds at the kind of very senior level. It's just, if anybody looked at that political programme In the Thick of It, that's pretty close to, it's pretty close to the way it is if you're close to politics. Yeah. So that certainly is the case. I think, the pandemic was absolutely the most chaotic situation that we could have been asked. There were situations that were wholly novel to me in that. For instance, dealing with the social care sector. It was not something I knew very much about at all. And there were other parts of that pandemic, which, basically I hadn't really trained for at all. And we had to make decisions under the circumstances. Now, the first thing is, are you brave enough to make the decisions and take the consequences for that? This is the extreme, by the way. Registrars will not be in this situation. But, the second thing is, you're going to be the name on the frame when it comes to why did that happen. So public inquiries, I was involved with Grenfell as well quite a bit. I had to take over some of the local situation there when things were going wrong. And, was dealing with some very angry people. Your name is in there. You have to be ready to actually stand up and explain why you did it. And even if that is painful or if it can be, tricky, you've got to be honest about it. And we have some big honesty questions coming forward in the next phases of the pandemic. So these are things you prepare for carefully, but you tell the truth. And if you've made the decision, you've been brave enough to do that, because some people will not make a decision either because they're afraid. So these are all leadership qualities at the most extreme.
Really inspiring to say that about really bravery. It was probably my kind of takeaway from that, of being brave and confident in your own ability. So especially, the number of chaotic situations you've been in. And I probably will rewatch the thick of it now that you've sort of mentioned that. So sort of moving on a bit to kind of communications and media. That's another kind of important skill for registrars that we develop, whether it's reactive media interviews, writing press releases, that kind of thing. Having been on sort of many podiums, during COVID-19 and done, a lot of media interviews, I wonder if you could give us sort of behind the scenes of how you prepare for sort of media interviews and how you kind of approach things. Obviously, we've had our training about coming in with talking points and that kind of thing. But do you have a kind of a process that you use before you go to Sky News or BBC News?
Yeah, well, actually, I still do media, and I did Times Radio yesterday morning on cancer. So it's still quite prescient, really, in my mind. First of all, you have to like communicating. If you're a good communicator, that helps an awful lot. And remember, you're talking through the interviewer to people who don't necessarily think about this every day. So can you explain what you're trying to say? And the number of people who I hear coming along with reams and reams and reams of statistics and facts, and they forget who they're talking to. They're giving a lecture to their colleagues or whatever. It isn't like that. If you're on general media, first of all, have your audience in focus all the time. I always prepare carefully. I don't take media lightly, even if it's quite a trite set of questions. I look up, personally, this is what I do. If there's a paper reference, I'll do a Google or PubMed search, make sure I know what the basic stuff is saying. If that's not possible, I'll go to trusted sources to make sure I have my data in my head. And then prepare my key points, certainly. The other thing is as you're kind of preparing for it, you need to know what kind of interview it is. I like to know the name of the interviewer so that I am personal on the interview. I also like to know a little bit about what the audience is. If it's not obvious, I need to know who listens to this. That's very important if you're doing local radio, because it can be quite segmented as to who you're speaking to. And be colloquial. This is a huge skill. Be colloquial and be understandable, but be very factual. So you're not there because you're Kazim. You're there because you're the Director of Public Health for the area. So lots of people, I've been at some tricky ones. I was at the Confed last year with Steve Powis, and I think it was last year, it was very recently anyway, and they asked me what I thought about Boris Johnson's, we were in a kind of chat like this, what did I think about Boris Johnson's kind of media parties? And I said to them, look, if you want to know what Yvonne Doyle thinks about that, I'll meet you in the pub down the road and we'll have a chat over a pint. But you're not asking me that. You're asking me as the medical director for the NHS, and it's not my job to tell you what I think about wine parties in Downing Street. That's not my role.
Sound bites are great for public health in a way, but also can be quite dangerous as well, right?
Yes,
How do you really have to think about the preciseness of your words that could be taken out of context? Say, Yvonne Doyle said, Boris Johnson, blah, blah, blah.
Yes, so you do. But, be sensible about this. First of all, don't treat the interviewer as your enemy. The interviewer, what they want is a scoop, of course. And if you give one, that's great, thank you very much. But mostly what they want is a good interview. So I did Woman's Hour after the pandemic inquiry last November. And of course, people think, Woman's Hour. Well, actually, Woman's Hour is listened to an awful lot of people. And what they wanted was some dirt on Matt Hancock, the Secretary of State. And I wasn't going to give it to them for the same reason as the Confed thing, because it isn't my job to talk about Matt Hancock, except insofar as our interactions were factual. It was my job to get beyond that and say why this was actually a situation that was extremely professionally challenging. And so you've got to understand and think through the angle you're trying to explain while not giving the kind of sensational stuff. And then we moved on. Well, she said, you seem to be very equipoised about all this. What does motivate you? And I said, well, what motivates me is the fact that 2 million people are out of work. What's going on there? And a lot of those are young people.
Yeah, no, I did. I do remember listening to that, actually, and she was very much trying to press you multiple times on what you thought about Matt Hancock almost as a person. But sort of, I guess, related to its kind of media, social media and public health during COVID-19, social media had a huge impact on, accessibility of information, public health information to sort of regular people. What's sort of your approach to social media, sort of Twitter or X, or Instagram or that kind of thing? Do you see it as a good tool for public health practitioners to be on? And what's your sort of approach to social media?
So I think it's very useful, and it's out there and it's part of reality. There are big questions about its impact on certain vulnerable groups. I have come off it. I don't tweet anymore, or tweet or X or whatever you do these days. What is the actual operational word?
It's called X at the moment, but everyone still seems to.
So what do you do? Do you tweet? Yeah, well, whatever you do.
It feels weird to say I just X.
I just X, yeah, exactly. Whatever it is, I don't. And I found that in the spirit of what I was just saying, it was taking me a long time to tweet because I didn't want to put just any old thought on. And I don't like the idea of, I think that's great, or, yeah, well, she was right, wasn't she? That sort of stuff. I think if you're giving information, again, people are interested in you because you're the director for London or the national director. You give them something that is of value. This would be my personal value. It isn't what everyone would do. But that was taking me up to a half an hour a tweet. And when I was really busy, now it didn't take that long every time, but when I was really, really busy, that was just too much time. And then I started sharing other information. I thought, actually, who's interested in that, really? Yeah. And then I thought, no, I can spend my time better in other ways. But I do read X. I mean, I do link into it, and I think it's a very useful way. And obviously the faculty use it, and others do, for putting out stuff. Yeah. And in that sense, it's very good.
There's a lot of noise on Twitter and social media, I would say, and not a lot of it is necessarily useful. And a lot of it seems to be sort of commentating on things rather than, as you said.
I don't like commentary. On the other hand, I think some of my colleagues who are probably much more tech savvy than I am are very good at quickly sharing stuff that's useful. And I got to that point, and then I thought, still, there are others who do that better. So, I think there are ways of making it useful.
Yeah, completely. So looking sort of forward, I know we've sort of reflected a bit on the past public health challenges of COVID-19, touched on that a little bit. I guess looking to the future, there are a number of challenges on the horizon. Some are talked about more than others. What do you think are the big public health challenges ahead that you think we aren't talking enough about?
Well, I think there are two elements to this. There is the population things we're not talking enough about, and there's the specialty, the professional things, us as a faculty, as a specialty. So with the population, you could think of any number of issues at the moment with the state of health of the population, which are not getting enough airtime. And unfortunately, those who shout loud, and there are certain disciplines and specialties that shout very loud and get a lot of attention. And there are also go-to people who have particular bees in their bonnets. I would say that the early years, giving every child the best start in life, the first years of life are not getting either enough attention or enough funding. And think about it in public health. This was one of the areas public health commenced in. It started for this very reason, both infections but also the health of children. And it's poor, it's really poor. And the Academy, last night I was listening to their publication on the health of young children, 0 to 2 years of age, and the emphasis there going on children's mental health. We're not getting enough focus on that as at national level, at government, at funding level. And then at the other end of life, I mean, there's a lot in between, obviously, but at the other end of life, and I'm in it now, I did my MD on successful ageing. Now, older people like me have an awful lot to give society, and do. But I think they're kind of positioned and they're caricatured as dependent, a problem, the ageing population, we could do without these people. Or, we should be keeping it. Why did our 99-year-old gran die in a pandemic? Now, I know that's slightly perhaps disrespectful to say, but, for goodness sake, older people deserve a little bit more common sense and respect than this. They can and do a lot more. They need, I think, to prepare for old age and for later years in a way that, in the true public health style, keeps them the best they can be. They don't have to be perfectly healthy, but they need to be confident enough to realise that their health is such that they can give more. And therefore they should be recognised and respected for doing so and asked for it. It's not easy to volunteer. I mean, people tell me the routes into it are difficult. I've been lucky, people have asked me to do what I've done. But, if you're just starting cold, you give up pretty quickly. So at that end of life, health is important, and we don't focus enough on what people can do rather than what they can't do, and they're burdensome. And at the early years, crucially, how to give them the best start. That's for the population.
Yeah, I completely agree. Public health, as you said, really started in that early years priority, and the ageing ageing well, that's been a huge priority of yours throughout your career.
Yeah. It's really important, and thankfully a few other people are onto it, but I think we haven't really, in the way that the US has, for instance, where they really are very active older people, we haven't quite got there, where people are, even the signs on people are little old bent people on sticks. You know, that's not what it's like. I mean, we're quite a feisty group now, and we have a lot to give. Now, on this professional side, we're not speaking enough about the state of, I would say, not disrepair, but the state of disengagement of the various parts of the public health system. In other words, we're no longer really a pathway. I mean, the NHS, health protection, local government, you really struggle, and I know this because I try to do it from within the NHS, we really struggle to make those connections real, so that there are realistic connections between the healthcare system, the local government system in public health, the health protection system, and others, the academic, which is almost at times completely cut off from the rest. So our evidence base, there's wonderful stuff out there that isn't necessarily flowing. And part of that is the way the system has been designed, Kazim, and I'm going to say something quite, I think, important for me, is I saw the breakup of the public health system in various components through the 2000s, but particularly since 2010. Now, you know, some parts of that have been inspired in how they've taken up the, you know, the challenge, particularly local government, which is, you know, a very difficult environment, but I have huge respect for. So this is good. We're not saying there shouldn't be public health there, but the disconnect between that and the NHS, between that and the national public health system that was, and now we've got even a more specialised agency, this worries me a lot. And I don't think it's the best for workforce development either. You know, how do we... No wonder people are having problems explaining what public health is. And then we have the department, you know, in there, so people getting more and more sucked into central government. But who speaks? Where is the voice now? And you'd have to think carefully about who can say what in this situation, and who knows enough about the comprehensive picture of public health to say what. Yeah. And therefore, you know, the role of our chief medical officer is very important, but that needs other voices, it needs other advocacy as well, and that worries me. Yeah. And I'll say that because having now been semi-retired, I can say things that I couldn't say actually as part of government. Now, responsibly, I'm not going to go mad and say mad things, because that discredits us all. But the feeling of freedom and the feeling of being able to say things and having a helicopter view of the system is quite empowering.
I mean, just when you sort of mentioned there about the changes, I guess, since 2010 and obviously before that as well, but organisational change seems to be for registrars and consultants to deal with. And it's often outside of our control. I guess what do you think are the best ways of, I guess, dealing with change to organisations that's completely outside of our control and often, as you said, can fragment the system to make it less effective potentially?
Well, that's why I find the Director of Public Health role such an enabling one. And actually the regional directors, although they are part of government, they do have, you all have this helicopter view of the system, and that is tremendously important. And, you know, the place-based stuff with everything in it gives you that kind of perspective on what is going on with our population. And, you know, directors of public health can speak, you know, as long as their counsellors are behind them on the health stuff, they can say things. So I would say get exposure to all parts of the system. It's very important that people don't become super kind of cornered into one part. Oh, I only do, you know, local government. I haven't a clue what goes on in health protection. I never see the NHS these days. That's really bad for public health, because all of these components contribute to the population's health.
The sort of small comment you made about, I guess, the changes of from PHE to UKHSA, I think was had quite a huge impact, and obviously the timing was challenging as well of when that happened. And now we've gone to some sort of more specialised organisation. But are there other aspects now that you're outside of that environment reflecting back that you think could have gone differently or would have benefited the system in a different way post COVID-19?
It's very difficult to say this. And I mean, I'm saying this from my WHO perspective. I've seen how other countries are trying to organise their public. In fact, I was on an expert group in Ireland for the reorganisation of the Irish healthcare, the Irish public health system. And the Germans are now moving into trying to think about what their public health system should look like. And everyone has looked to England, particularly, because they felt that this was a very good model of a national, distributed regionally and then connected into local government and the NHS as an important component of it. But when you look at how it stood up during extreme pressure, I think there we have not fully reflected on what it was about that previous system that worked really well but didn't work. And unfortunately during the pandemic there was a race to set up all these new things, and there was a race in 2010 to set up a system because at that time the primary care trusts were not really thought about in manifestos. So there was a kind of reaction to put people somewhere. And the same thing during the pandemic. We've got to do it this way. And in fact, it would have been, in my humble experience, wiser to wait a little and then to think what is, for the system and for the health of the population that we are now facing, what is the best public health system. And that needs to be said a little more. I'm not preluding a new reorganisation. I think we're exhausted with it. But, what is there has to work in a comprehensive way for the overall health of people. And people do get sick, and I'm saying this now from a hospital's perspective. I spend all my time getting the hospital to think about the value of the healthcare that they're giving and the inequalities that they're experiencing. So it's a really important component, but it's not obviously where health happens. It happens out where local government is.
No, exactly. And I guess from a registrar perspective, we're placed across the system. But once we're consultants, do you have any tips about how we can be better advocates of, I guess, knitting those different things together, in the sort of potential absence of any sort of systematic change?
Yeah, so I think this comes back to your role as an individual and as a leader. So you can be a good advocate from whatever base you're in. I would say that, given a very disjointed system, some people get platforms and they get known and they like the kind of attention they're getting, and they use the platform in a distressed system to get attention for themselves. You've got to think, why am I doing this? What is my message? And who benefits? Always who benefits. So you can advocate, and advocacy is important. It's not very popular at the moment, but it is important. But I think it has to come with all the skills of delivery and of evidence and all the things that you get taught in your knowledge base as a registrar. And then you take that into your leadership role and you say, who is going to benefit from what I can do here?
So we're coming towards the end of the episode. It's been a really great conversation, and it's a sort of tradition on the podcast to end with a career tip for those training in public health. So what's your sort of one career tip that you would give to those currently training in public health?
Remember, you have a privilege, and privileges have costs, and it won't be easy at times, so persist. And remember that the people who won't shout are probably the people who are benefiting from your efforts.
That's great. Yeah, great note to end on. Persistence. Yeah. Thanks so much, Yvonne, for joining. It's been great to host you on the podcast. And thank you so much for engaging with us.
Thank you very much, Kesem.